and tympanic membrane retraction are both obviously immensely common conditions that you'll see in every pediatric ENT clinic, let alone pediatric otology clinics. And we're going to go through them one after another, as it were. So, super. So, talking about glue ear first. So, essentially with glue ear, you see a patient who comes to your clinic with glue ear or who's just had grommets and so on, and you know that you're going to get through this clinic appointment in 5 minutes because the audiogram and the tympanogram are going to tell you much of what you need to know, whether there's glue there, what the hearing level is, whether the grommet is patent or not, and so on. And you can have a quick look in the ear and say to someone, oh, that's all fine, and send them on their way. Or, you know, if someone has glue and they haven't had surgery yet, you're going to say, oh, it's very straightforward. You've got, you know, 30 decibels threshold, and so we'll just arrange to see you in 3 months' time, and that's what the guidelines say, and so on. And it is a little bit of a pity that the guidelines, whilst immensely useful, do reduce what is quite an interesting condition, and obviously a very important condition, which we understand incompletely, into really such a brief consultation, which really takes away any of the responsibility that we have of considering the condition. So just thinking about those of you who are at the beginning of your careers, some basic questions, as it were. The first is, what is glue ear? So glue ear is a collection of fluid in the middle ear cleft associated with an effusion, essentially. And why do you get it? We think probably it's to do with eustachian tube dysfunction, causing inadequate aeration of the middle ear cleft and the mastoid, and that then causes hypoxia, which causes inflammation in the mucosa, and then leads to production of an effusion. And it's to do with the relative degree to which air will be absorbed by the mastoid mucosa, meaning that fluid then has to fill that space to buffer against pressure loss and so on. And the NICE guidelines for management are relatively straightforward, and essentially they say that if you have a hearing loss of greater than 25 to 30 decibels tested on average, tested at a 3-month interval, then NICE would recommend proceeding with grommet insertion. Although we talk about that as a funding purpose, but actually really that's a funding restriction, because essentially what it says is that if you don't meet these guidelines, your surgery won't be funded, or rather that's how a lot of CCGs have interpreted the procedure. And so we often think about grommets as procedures of limited clinical effectiveness, or planned procedures with a threshold at which they'll be funded and so on. So the NICE guidelines really work as restrictions. For those of you at the beginning of your career, there's a brief video on how you insert a grommet. And obviously after clearing the wax and so on, you make a radial incision in the tympanic membrane, release a load of glue or fluid, and you can see it's slightly discolored, quite a watery effusion here. You suck it clear, and this looks like a medium stay grommet that's being placed in. It goes in the eardrum quite easily. So what are the issues we have with the NICE guidelines? It doesn't really engage us with the pathophysiology, which is probably quite different in different patient groups. What causes glue ear when you see it in adults is probably quite different from what causes glue ear when you see it in children. There are some particular subtypes of glue ear, for example, eosinophilic otitis media with effusion, which the guideline doesn't really pick out in any particular way. And whilst it does pick out some specialized group, particularly Down syndrome, and to a lesser extent cleft, it doesn't take into account a number of other specialist groups who can get glue ear. Patients who have had radiotherapy, for example, or patients who have ciliary dyskinesia or issues like that, aren't really accounted for within what is quite quite a clear guideline, and obviously there are advantages to it being clear, but it does take away a little bit of the art side of medicine and the accounting for individuals. You also have to consider single-sided hearing loss. So 20 or 30 years ago, certainly single-sided hearing loss was considered to be much less important than we consider it to be now. There's a lot more evidence pointing at academic attainment and so on. For patients with single-sided hearing loss, they have a greater effort of hearing, speech and noise, particularly when the deafened side is facing the speaker, is inferior. And these kind of things, particularly in a noisy classroom environment, tend to cause problems. It also doesn't really go into post-operative care. Whilst it will give a good indication of when you should put a grommet in or put grommets in the first instance, it doesn't say what you should do when the grommets extrude, and like a significant proportion of patients, probably in the region around 20 to 25%, the glue recurs. There have been other studies suggesting that adenoidectomy and so on can be helpful in this instance, but on the other hand, the article the guideline doesn't really kind of elaborate on this very much. So we might ask why that is. And essentially, the reason why is because it is a guideline, and guidelines have to be clear in order to be of any use. If we consider things in greater depth, we might consider about some of the causes of glue ear. So we know that there's a very large genetic component to glue ear. We know that because you see the probability of having glue ear if you have a first degree family member who has glue ear is many, many, many times greater than if you don't. We also know that there are environmental factors, particularly exposure to smoke, and that's why you have various ethnic groups, particularly people often talk about Inuits having a very high rate of glue ear, although some groups who are less exposed to smoke also have very high groups, for example, Aboriginals. We think that the pathophysiology is to do with eustachian tube dysfunction, as I talked about before, but we also know that infection and immunity plays a role. Infection, we have a lot of evidence that infection plays a role. This is to do with the incidence of glue ear that you see at different ages. You have peaks around the age of 2 and around the age of 5, which tend to be the ages at which children start to socialize with other children much more, at the start of primary school and when they go to nurseries. And anyone who has children, I'm sure, will know the number of bugs that you can bring back from these kind of places. We also know that children who have immunodeficiency, and indeed also adults who have immunodeficiency, are much more likely to get glue ear. And so certainly infection plays a role, which doesn't fit particularly nicely into our concept of this being purely associated with eustachian tube dysfunction and hypoxia. There's also a link with cilia function and upper aerodigestive tract inflammation, and this is particularly seen in patients who have conditions like Wegener's disease or primary ciliary dyskinesia, or who've had radiotherapy in this area and so on, who are much more likely to get it. If you particularly want to impress people on your Viva, you can talk about some of the genes that have been identified that might be linked to it. You can talk about some of the environmental factors, the role of breastfeeding, particular anatomical factors for the eustachian tube, the high incidence of glue ear in the patients with craniosynostosis, and links with allergic rhinitis and how that's a factor in terms of infection and inflammation affecting the upper aerodigestive tract and then the middle ear, and associations with, as mentioned, Wegener's disease and chronic rhinosinusitis and so on and so forth. Another interesting thing to consider is the degree of hearing loss that you see with glue ear. Obviously, in Cambridge, they've done a lot of work, or Professor Vance has done a lot of work on middle ear mechanics and modeling how the tympanic membrane moves and how the effect of middle ear effusion will change that. But it is true that the amount of hearing loss we see with glue ear is actually more variable than we might expect. You see patients who have glue ear who have maybe a 5 or a 10 decibel airbone gap, and then patients who have a 40 decibel airbone gap. And that's not really particularly straightforward to explain. It seems almost instinctive that the viscosity of the effusion should play a large role. However, actually studies haven't really borne that out. Certainly the volume of the fluid does appear to play a role, and it might be that something to do with the difference in the volume of the fluid in the middle ear and whether there's any aeration at all will play a role. But it may also be to do with particular anatomical factors in the ear, the angulation of the tympanic membrane, for example, and mucosal inflammation, which we know can impede auricular function. So subtypes of glue ear. The most particular subtype I'd like to talk about is eosinophilic glue otitis media with effusion, which is relatively infrequently mentioned, but the management really is quite different. Eosinophilic otitis media with effusion is commonly seen in asthmatics. It's commonly seen in association with nasal polyposis, and the outcomes from management are significantly inferior to the outcomes you might expect for glue ear. Usually you have a very, very firm and viscous effusion, and you have a much higher rate of discharge associated with grommet insertion and a failure to improve air conduction. And so the eosinophilic otitis media with effusion is more commonly managed with hearing aids, be that dim conduction or air conduction and so on. Recurrent acute otitis media also puts you into a slightly different type of glue ear, because you're much more likely to want to intervene with these patients. You're less likely to wait for 3 months. Recurrent acute otitis media, defined by 3 or more episodes over a 6-month period, really is a relatively low bar to be considering grommet insertion, and that's because the effects that otitis media with effusion can, the effects of acute otitis media on children. You have glue ear in combination with retraction, and obviously we'll be talking about retraction previously shortly, and then obviously you have to consider the unilateral middle ear effusion, which when you decide to do a grommet, you have gin clear watery fluid coming and continually coming and so on. And there have been a number of cases in which grommets have been placed in patients who have had otogenic CSF leak, and obviously placing a grommet in those cases is not the thing to do. So talking briefly about recurrent acute otitis media, I think the interesting and slightly enigmatic thing about this is that the most recent systematic review article from Mushir Hussain in Dundee suggested that actually probably the most effective treatment was long-term low-dose antibiotic treatment. However, the NICE guideline specifically indicates that these shouldn't be given and strongly recommends tympanostomy tubes. Obviously, the effect of COVID on this puts us probably even more firmly into the long-term low-dose antibiotic group. But obviously, if you have glue ear with an accompanying hearing loss, then you'll move towards grommet insertion. In addition to those groups, obviously the specialized groups we mentioned before, Down syndrome, you'd like to manage them with hearing aids because they have a very early rate of extrusion. Grommet insertion can be technically difficult, particularly in the Down's children under the age of around 2 or 3 years old, and there's a very high rate of grommet-related otorrhea. Cleft, we perform grommets in cleft much more commonly, often at the time of their cleft surgery. The outcomes, it's true, are worse, and you have a much higher rate of persistent glue after the grommet has extruded, but it's also true that cleft surgery has been shown to improve the function of the eustachian tube, and so a significant proportion who receive a grommet at the time of their cleft surgery, when the grommet extrudes, the eustachian tube will have developed to maturity to mean that the patient doesn't require grommets anymore. PCD, we tend to manage conservatively as much as possible, and if they have sinonasal disease, treatment of the sinonasal disease can be beneficial for those patients. patients with 22q and other immunodeficiency syndromes, it's important to identify those patients, although generally speaking, we manage them as normal with grommet insertion. And the same for patients with craniosynostosis. You might consider in patients like, particularly patients with craniosynostosis, whether to put a long-term grommet, as their rate of extrusion is significant and their rate of recurrent glue afterwards is quite high. And obviously you'd like these patients to have as few operations as possible. Unlike cleft surgery, mid-face advancement surgery for craniosynostosis tends to be less effective at improving the eustachian tube function. For a long time, people thought that patients who have been treated for nasopharyngeal carcinoma tend to have very, very poor outcomes from grommet insertion. However, really the evidence doesn't necessarily bear that out, and certainly grommetic insertion can be considered for those patients. The other thing to say, obviously, is that the guidelines specifically are for the children of the age of 12 and below. And actually, you do get grommet, you do get glue in, you do put grommets in children above the age of 12 and adults above the age of 12. And really, you have a lot more freedom in these patients to consider how you'd like to manage them. We put a lot of grommets in for children who have cochlear implant assessment because the incidence of glue ear below the age of 1 is actually surprisingly high. And given that you want to implant children before the age of 1, or preferably even around the age of 9 months, assessing them in a timely fashion instead of waiting for glue to clear is worthwhile. And so you'd have a very low threshold to insert grommets just to cut, a couple of months off the time at which you might implant someone. When you consider about individuals, you also think about what other points might be particularly relevant. This is a patient I saw in clinic recently. You can see that on the axial T2 weighted scan that they've got a left-sided middle ear effusion. And obviously the NICE guidelines would recommend that you wouldn't put grommets in this patient, but they have a certain amount of nasal obstruction. And actually this is the way that their postnasal space sarcoma has presented. You need to consider that obviously even patients below the age of 12, a guideline is just a guideline and you might want to manage an individual patient quite differently. Single-sided deafness, as I mentioned previously, was not considered to be an issue. And to be honest, the issue that it probably has is on patients who have the long-standing single-sided deafness. And the effects that has on listening effort, speech and noise and localization cause an impact on educational outcomes and probably a lesser but potentially potentially important impact on speech development, and that's particularly for families with multiple children. When we talk about post-operative management of grommets, we think about the complication rate and our follow-up strategy and so on. It's probably worthwhile to note that the complication rate is usually underreported. So the incidence of grommet-related otorrhea in children who have grommets is probably as high as 1 in 5 or even maybe 1 in 4. A significant proportion, maybe 1 in 20, will have early extrusion. And focal atrophy of the tympanic membrane can also be seen in about a quarter of patients. And this is particularly relevant for retraction, but it's important to consider this kind of complication when you counsel a patient to have grommets. Follow-up strategy, generally speaking, patients are seen 6 monthly post-operatively on the NHS, although privately they're quite frequently seen more frequently, and that may represent a higher standard of care. We've got to wonder whether seeing these patients every 6 months when we only want to observe a child who has a hearing loss for 3 months is due to funding constraints, or whether it's due to or whether it actually represents optimum care. Adenoidectomy obviously has a role in these patients, particularly when they come into their second sets of grommets. So in summary, glue ear obviously is a very common condition and its pathogenesis is immensely complex, but actually for the vast majority of patients, the guidance is incredibly clear, and so management of these patients is actually relatively straightforward. You should still consider each patient carefully, and certainly there are a lot of patients who will be an exception to a rule, and overlooking them can be quite detrimental to them. But in a way, it's quite different from retraction, which is a really enigmatic condition, which, whilst also incredibly common, the guidance on the management is much less.
Really excellent talk. If we can start on glue ear. There's a question about unilateral glue ear, and I know, Rob, that you mentioned about single type hearing loss. So I guess there are funding restrictions in lots of places about putting unilateral grommets in.
I think we're quite fortunate in that actually the commissioners and the funders don't really tend to question what we do. And so actually we get away with putting a unilateral grommet in the kind of particular circumstances in which it might be indicated. I think obviously the effect of a unilateral hearing loss is many times less than the effect of a bilateral hearing loss. But a persistent unilateral hearing loss, particularly in a patient who has a higher volume of glue and probably a higher hearing threshold, we'd certainly consider, particularly if you have a child who's struggling at school and so on, and you want to do everything you can to try to improve the situation. Also, there are times when you have a unilateral glue ear and you have a patient who's coming for intervention for some other kind of reason. They may be having cleft surgery, or equally they may be having neurosurgery or general surgery or hernia repaired or something like that. And then you really think that the risk and the benefit really does change if you've got a patient who's coming in for surgery anyway. So yes, obviously the NICE guidelines do restrict funding, particularly for those kinds of cases. However, there are clearly cases where intervention is in the best interest of the child. And so just because the guideline said that, I don't think we should entirely overlook it as a possibility.
And can you also comment about the use of long, so for example, permanent tubes, associated complications, and also whether you think there's actually any difference between the different types of long-term ventilation tubes?
Yeah, so I certainly think that there is a difference between the types of long-term ventilation tube, and also not just the types, but the ways you can put them in. So the indication for putting long-term tubes, I mean, there are various indications. You might have a patient who has done well with ventilation. For example, they may have cranial synostosis, say 6 or 7 years old, and you think the chance of them having a functioning middle ear in the next 5 years is actually relatively low. A patient like that might be a good candidate to have a long-term tube. Obviously, the downside of a long-term tube is a much higher rate of persistent perforation, and also a much higher rate of grommet-related otorrhea. Now, when it comes to picking the individual tubes, in my experience, the medium-stay grommets last marginally longer than routine sharp grommets, maybe twice as long, something like that. If you want a tube to last for a long period of time, then I think the conventional T-tube really is the best. Personally, I am not a big fan of the extra-annular T-tube, where you lift a tympanomeatal flap and drill a notch in the bony annulus, place a T-tube within that, and then place an intact tympanic membrane down over that. I think that has the benefit of obviously not interfering with the tympanic membrane, and the extra-annular T-tubes do last for a very long time, potentially indefinitely in some cases, but you do get problems with infection and keratin building up around the tube, which is kind of appearing under your flap and so on. And that's the reason why I haven't been a particularly big fan of them. But I certainly think a case like that have a role. A colleague of mine has a lot of experience placing medium-stay grommets immediately anterior to the handle of malleus with either tie of the grommet either side of the handle of the malleus, and they stay in situ almost indefinitely. The difficulty with that obviously is that you have a high incidence of persistent perforation, and you have a high incidence of persistent perforation in the part of the tympanic membrane that is the most difficult to graft. Although obviously you can raise the tympanic membrane off the handle of the malleus and put a graft in, and you've got the handle of the malleus there to lateralize your graft, but it's a more difficult place to heal. But then you have a tube in place for a long period of time, which for a lot of these patients is invaluable.
Okay, thank you for that. So there's also a question, I think you've touched on this, but what's your opinion on grommets for recurrent acute otitis media?
So I think they are a good intervention for recurrent acute otitis media. I think that the incidence of grommet-related otorrhea with those patients is actually not particularly high. And I think the issue, or the reason we don't do it more frequently, is because recurrent acute otitis media is essentially a condition of the under twos. And because of historical MDT guidelines on ENT surgery on children under the age of 2, it's largely been restricted to paediatric centres or larger hospitals, and that means that operating on children under the age of 2 is difficult for a lot of ENT centres, and that's why, or that's one of the advantages of long-term low-dose antibiotics, in that it can be given anywhere. But I think grommet insertion is probably a marginally superior intervention, in my opinion, although I accept Rishi Hussain's paper that actually maybe it's not quite as straightforward as that. But grommet insertion also has a secondary benefit of helping the hearing, particularly for those who have glue. So for children who have glue, hearing loss, and recurrent acute otitis media, it's the only intervention I offer. I don't really even talk about antibiotics in those patients.
Thank you. You also touched on eosinophilic.
Eosinophilic, yeah.
And is that something that you've seen much in children? And if so, what alerts you to it? I mean, I mentioned about asthma.
So it's asthma and nasal polyposis.
Mm-hmm.
And you see it infrequently in children, because in children, particularly children below the age of 8 or so, when you see really extensive nasal polyposis, you consider PCD and cystic fibrosis and so on. So you've got other concerns. Eosinophilic otitis media are seen more in adults.
There's a few questions now about retractions. So and perhaps Rob, you can also chip in, but what's your take on management of asymptomatic retraction pockets in children? So the ones we often see are the ones, for example, sitting on the incus, it's starting to erode. They may have good hearing, no cholesteatoma. You're following them up for some time. There's no progression. What does the evidence say about that, and what's your opinion?
Yeah, if you go back to the slide talking about whether or not the plus points for offering a tympanoplasty and the minus points against offering a tympanoplasty, because really you've got to consider each case as it is. So if, for example, you have a stable, so essentially you're talking about an asymptomatic but stable retraction. If you have that in an older child, someone who's kind of 14 or 15, 16 years old, and they've got an airborne gap on that side of 30 or 40 decibels, and they can't swim, and they get otorrhea, you said it's asymptomatic. Then essentially you consider, is the hearing loss sufficient to consider a tympanoplasty or cycloplasty? But if you've got a stable retraction, at any age with good hearing, no episodes of infection, then really you've got a lot of factors that really go against operating. So if there's hearing's normal, no infections, no sign of vesicular erosion, really, and the retraction is stable, it's really hard to think of any reason to operate on that child. But obviously each case is different, and there's no you must do this or you mustn't do this. It's all about looking at the factors in favor and against each option that you consider.
So I guess just to summarize that in some ways is, if they're asymptomatic, you would so without hearing loss and without infections, you would tend to leave it until it became symptomatic, on the basis that in fact probably most of them won't become symptomatic. Is that?
Yeah, I think that's a reasonable way of describing it. Yeah.
Okay. So if I can ask you, Rob, so your indication for inserting grommets with a retraction, is it only if there's glue ear, or do you do it in other situations as well?
So I do it in other situations. once again, it's really hard to be entirely kind of matter of fact about you do it at this age or that age or this kind of thing. Broadly speaking, the younger children tend to be more likely to put in a grommet in them, and that's because broadly speaking, when you're older, and particularly in adults, it's more likely that the situation is not going to get better on its own. Whereas when you're younger, whilst the situation may have a period of time where it gets worse, there is a period of time when it is going to be getting better, be that around the age of 10, 12, 13, 14, something along those lines. And so the question is whether you can kind of get them through to that time without the situation worsening. Now, obviously, putting in a grommet relies on the assumption that tympanic membrane retraction is entirely secondary to eustachian tube dysfunction and inadequate ventilation of the middle ear, and that's certainly not the case. There's almost certainly some kind of mucosal traction, and Fiona went through some of the theories of tympanic membrane retraction, and a grommet is obviously not going to help with lots of those things. But it does, you do see cases where they have a notable retraction, you put a grommet in, it looks much better. That may be that when the grommet extrudes, it goes back to looking just as it was, and that was going to be the case anyway. And it may be that you then have an additional focal retraction where you have an atrophic segment after your grommet insertion. But if you've got skin wrapped around some ossicles in a patient who's getting recurrent infections and they're 4 years old, I prefer to put a grommet in the ear and see if that will elevate it, then put the patient through a full tympanoplasty.
Okay, yeah, that's clear. Okay, thank you for that. And then probably just time for one last question. So the question is, how do you manage the atelectatic retracted tympanic membrane onto the facial nerve and eroded stapes in an adolescent? And that's particularly raising the concern about the risk of keratin being left behind and cholesteatoma later.
So those photos gave kind of examples of the retraction you do want to operate on, the first one, the retraction you don't want to operate on, the second one, and then the last one, which is the retraction you kind of end up always operating on. Or when you do operate on a retraction, they always kind of end up looking like that last one. So this is one you really don't want to operate on if you can avoid it. So yes, you can use a laser and so on, and the laser is going to help you, or is going to reduce the chance that you lose some skin in the middle ear cleft. But you're going to want to be really quite circumspect about using the laser over the facial nerve, and you can see you've got a little bit of what's probably a residual stapes head sitting there immediately superior to the oval window overlying the middle of the facial nerve, and it might be that you get a little bit of skin left around there and you're not going to want to laser it and so on. And whilst taking retraction out of the oval window is usually relatively straightforward, taking it out of the round window niche carries probably a much greater risk. Your chance of having perilymph leak associated with that is much higher. And then there's a question about how much that goes into the attic and whether you're going to have to take off more attic wall. It's not a good case to do a combined approach to tympanoplasty to elevate the retraction for, because you can see that the erosion that the disease has caused has broadly speaking gone into the area in which you'd normally do a posterior tympanotomy to elevate a retraction from posteriorly, which is a useful technique and can be done on other cases. Also, once you elevate all the retraction, you've then got to reconstruct essentially with a TORP, and the long-term outcomes for a TORP are significantly inferior to long-term outcomes for a PORP, and particularly so in a case like this where you may have some ongoing retraction. You can see just next to the facial nerve a little bubble from the glue in the ear, so you might get, now whether or not that's glue is a pocket of glue caused by adhesion or whether it's throughout the middle ear cleft is hard to say, but if you do this, put in a torque, get it to work perfectly, but then they have glue and they have a 30 decibel air bone gap and they're no better than they were before, they're not going to thank you. So I would only operate on this ear if it was developing cholesteatoma. And I think the next point to say about that is you get retraction pockets who do get infections from time to time. You know, every 6 months they'll have some otorrhea, you treat them with some drops and it gets better. Now, if you see one of these patients when they're having one of those infections, that will look like cholesteatoma because there will be keratin in throughout that retraction. But I think the important thing to remember about cholesteatoma is that it's obviously chronic active squamous otitis media, and the important part about that is that it's chronic, so it's there for a period of time, you know, despite medical treatment essentially. So you could, if you saw this for the first time and there was loads of skin around and so on, you know, you send them for a scan because you think it's cholesteatoma obviously, but you do microsuction them and treat them topically, and when you go through the results of the scan and it looks like this, you're like, oh, actually, hold on, maybe this wasn't a cholesteatoma, maybe this was just an infection within the retraction pocket.
Okay, great. Okay, thank you guys. Thank you, Rob. That was fantastic talk. Really, really useful.